Hello, everybody, and welcome. Thanks so much for joining us today. So my name is Preeti George, and I am the project director for SAMHSA's National Training and Technical Assistance Center for Early Serious Mental Illness, also known as the ESMI TTA Center. So I think people are logging in right now. We'll give just a few seconds for people to log in. But we're very pleased to have you here on our webinar today on cognitive health in the coordinated specialty care context. So I think we can probably get started, I think. So we can go to our next slide. So as people are logging in, we'll just go over a few housekeeping notes for you. So our presentation today will be recorded. And during the presentation, it would be great if you would like to submit any of your questions or feedback in the chat. We'll have an opportunity to look through those, and we'll be asking you to engage and share information about yourselves in terms of your role and other pieces as you go through the presentation. So please feel free to utilize the chat. And also, you will receive these presentation slides via email after the webinar is over. So during our session today, just a quick overview of what we're going to be doing. So we will provide an overview of cognitive health in the coordinated specialty care context and discuss the 3 pillars of cognitive health services. At the end of our webinar, we'll have a question and answer session, and we'll go through some of the questions that you put into the chat. And then after that, we'll finish up with a few closing remarks and announcements at the end of our session. So for our webinar today, I'm so pleased to introduce our speaker, Dr. Ali Saperstein. So Dr. Saperstein received her PhD in clinical psychology from the University of Maryland at College Park, where she specialized in the study and treatment of people with schizophrenia. She completed a predoctoral clinical psychology internship at the VA Connecticut healthcare system, and she joined Columbia University as a postdoctoral fellow to pursue her interests in cognitive rehabilitation and recovery. Dr. Saperstein is an associate professor of medical psychology in the Columbia University Department of Psychiatry within the Division of Behavioral Health Services and Policy Research at the New York State Psychiatric Institute. And she has collaborated on numerous federally funded research grants, as well as local clinical initiatives such as On Track New York. And all of that centers on providing evidence-based, personalized cognitive health services for people who are receiving care in community-based settings. She is the director of Cognitive Remediation in Psychiatry, an annual continuing education conference, and a licensed psychologist at the Lieber Recovery Clinic and at the New York State Office of Mental Health. Please welcome Dr. Ali Saperstein.
Thank you so much, Preeti, and thank you everybody for joining us here today. I'm really, truly honored to be able to present this information and to do this webinar with you all. So I think it is helpful to set our intentions for the next hour or so that we are together by first reviewing our learning objectives. So the first thing that we'll do is to describe how cognitive health intersects with early psychosis, and then identify strategies for integrating cognitive health services into coordinated specialty care or CSC programs. We'll list the 3 pillars of cognitive health services, including asking about cognitive health to gain a mutual understanding of the role that it plays in an individual's wellness and recovery, assessing cognitive strengths and areas of need, and addressing cognitive health needs to support learning and engagement in the recovery process. Next slide, please. Great. So I think it is helpful to start with some definitions to place today's topic in the context. So coordinated specialty care is an evidence-based, recovery-oriented team approach to treating early psychosis that promotes easy access to care and shared decision-making among specialists, including the person experiencing psychosis and family members. There are several core components of coordinated specialty care, including the provision of evidence-based psychotherapy, medication management, family education and support, service coordination and care management, as well as supported employment and education. The effectiveness studies of coordinated specialty care support improvement in education and employment rates and decreased hospitalizations. But we do see variability in outcomes that may be impacted by several factors, including duration of untreated psychosis, employment and educational histories, cognitive health, symptoms, motivation, and self-efficacy. Next slide, please. So I did mention cognitive health as being one of those factors that can impact outcomes from coordinated specialty care. And it's important to recognize that first-person perspectives that were solicited through program evaluation and research do indeed highlight the value of addressing cognitive health concerns. We can pull data from various research groups and studies that have been published in peer-reviewed journals that have shown that thinking skills are rated as highly as school and social relationships when it comes to treatment priorities, and that participants of coordinated specialty care services identify the value of having better memory, attention, and critical thinking skills. Next slide, please. Research points to cognitive impairment as one of the earliest symptoms to manifest prior to other prodromal or even overt psychotic symptoms. We see cognitive, motor, and social impairments that may manifest in childhood or adolescence. We see cognitive performance impairments that can appear in people with early psychosis who are yet to be medicated. And we see impairments present in people who are determined to be at clinical high risk, who later develop psychosis. Next slide, please. If we think more broadly about cognitive health, we can think of the brain's ability to support thinking, learning, remembering, and the array of cognitive skills that are needed to perceive, acquire, understand, and respond to information. There are a number of cognitive skills that we use that are used in an interdependent fashion and allow us to do everyday tasks and things that are most meaningful to us. And we can summarize a variety of cognitive skills using an acronym, SMARTER, where each letter of the word SMARTER stands for a different cognitive skill. So the S in SMARTER stands for speed of information processing. So this is the rate at which we're able to take in and process and utilize and respond to information accurately without making errors. The M in SMARTER stands for memory. So it says being able to remember information that we've seen or heard. A is for attention. So our ability to focus on information that's most important to doing a task in the moment, and to even shift our focus from one thing to another when multiple things are happening simultaneously. Attention also refers to our ability to stay focused over an extended period of time. The R in SMARTER stands for reasoning. So reasoning, using logic and problem solving. T is for tact, which is a set of social cognitive skills. And E is for executive skills. So this may include skills like planning, organization, time management. And then the R is for reflection. And this really refers to metacognition, which we can actually think about two aspects of metacognitive skills. There's metacognitive knowledge. This is what a person knows about their own thinking skills, about their own strengths and areas of need. And then there's metacognitive regulation. So if I know that I have certain areas of strength and certain areas of my cognition that are less strong, I can then plan, monitor, evaluate, and adjust my approach to carrying out cognitively demanding tasks by selecting appropriate strategies to facilitate optimal task performance. Next slide, please. So when cognitive challenges are inadequately addressed, we see people having vocational struggles, social isolation, educational difficulties, daily living struggles. We see poor wellness management, and oftentimes we hear evidence of self-criticism and subsequent low expectation for future success. And we've heard people explaining that they have difficulty bridging their intentions to action. And by that, I mean, people will say, I know what I need to do. I just can't get myself to do it. Or I want to do X, Y, and Z, but I just can't get myself to start. Or maybe once they've started, they find it difficult to finish, especially when obstacles present challenges. Okay, next slide, please. So multinational guidelines for the treatment of schizophrenia and early psychosis recognize the importance of addressing cognition, raising questions about how to best integrate cognitive health assessment and care into routine practices. However, there are discrepancies between the treatment needs of young people in early intervention services regarding their cognitive health and the proportion who actually receive support. We can begin to fill this need by building what I would call a culture of cognitive health. Next slide, please. So, a cognitive health framework in an implementation context values the personal and practical relevance of cognitive assessment and treatment. Using a cognitive health culture or framework, we would integrate cognitive health into our routine vocabulary regarding wellness and recovery. So just as one would ask routinely about one's physical health or one's emotional health and well-being, one would also routinely ask about an individual's cognitive health. Next slide, please. Thank you. So from my perspective, all team members from coordinated specialty care services play a role in upholding this culture of cognitive health that values good cognition. All team members interact with an individual in unique ways and contexts that bring multiple perspectives on an individual's cognitive strengths and areas of need. Now, at this point, I would invite you to consider what your role is, whether you're on a coordinated specialty care team, or you're an administrator, or you're an advocate, or a person with lived experience. You can write your role in the chat. It's helpful to appreciate the vast array of perspectives that people in the audience have. See providers. Great. Clinician. Yeah, and if you're a clinician, perhaps there may be psychologists, there may be social workers, there may be psychiatric care providers, nurse practitioner, psychiatrist, apparently social worker. Excellent. Great. Provider, neuropsychologist, awesome. Great. So it looks like we do indeed have a variety of perspectives and people who have various roles. That's great. Excellent. Thank you. Yeah, keep them coming. It's helpful for me to understand who our audience is as well. And it's great to see so many different perspectives. So for the duration of this webinar, think about what your role is and how you can enact and uphold a culture of cognitive health in your setting and in your role. Next slide, please. Okay, so there are 3 pillars of cognitive health services, which I call the 3 A's: ask, assess, and address. And we're going to go through each of these A's in series, and we're going to start out by considering ask. This means understanding how good cognitive health supports wellness and recovery. So how does cognitive health align with a participant's goals and values? Next slide, please. So I suggest that we use what's called a cognitive lens. This means considering what one experiences, what a participant experiences, and what a clinician or another person might observe in terms of a person's cognitive health. So we're going to do another exercise where we're going to go through an example. And then think about how we can use a cognitive lens. So next slide, I will read this example aloud and then ask you a question. Okay, so at age 8, Chris was diagnosed with attention deficit hyperactivity disorder, ADHD, and grew up feeling as though he was always doing something wrong and was not as smart as other kids. He loved playing video games and became interested in coding in high school. Midway through college, while studying computer science, Chris experienced a psychotic episode. Following hospitalization, Chris started working with an on-track coordinated specialty care team. Now at age 22, Chris lives at home with his mom. He's back in school and says he's motivated to finish with the goal of eventually working in information technology. However, he's falling behind and in danger of not completing a required class. Chris's mom works full-time. She's concerned because when she comes home from work, she finds he's not moved from the couch and has played video games for much of the day. Okay, next slide, please. Which of the following is most likely true of Chris? And we're going to launch a poll to see what you all think. So would you say, given the scenario, Chris is lazy? Is he confused about what he really wants to do with his life? Is he depressed? Or is he struggling with focus, prioritization, and motivation? I'll let that simmer for a minute. Put your responses in. Thank you to all those who have put their responses in the poll. Super. Okay. Oh, still going. Great. So I'm gonna close the poll and let's see if I share the results. There was consensus that Chris is likely struggling with focus, prioritization, and motivation. So given the topic of the day, you might guess that that was the answer that I was going for here. But in truth, we can't make assumptions. We don't know. And my point here is that we need to ask questions. We need to explore this with Chris. We need to use this cognitive lens to consider whether a focus on cognitive health may indeed be underlying what we observe and what Chris is experiencing. Next slide, please. So we can ask ourselves, would a focus on Chris's cognitive health help him to follow through with his goals? And we can ask Chris directly, does he identify that good or better cognitive health would be valuable or useful to him? So asking about a person's cognitive health and their experiences and placing it in the context of wellness and recovery facilitates the next steps, which would be assessment. And let's go to the next slide. So now we're going to consider how to assess for cognitive health needs. Assessment practices might start with procedures that prompt discussion about specific cognitive health needs. So what would be helpful for the participant to improve? How might improving memory or attention or critical thinking skills be useful to a person? Next slide, please. So direct query and report of clients' experiences is a valued component of measurement-based care and supports individual agency in identifying priority areas for treatment. All coordinated specialty care participants can be asked to report on the value of having better cognitive health. And this can be done systematically at admission and at distinct follow-up time points. So if we look at what's on the screen here, here's an example of how we can assess for cognitive health needs. What you see on the left-hand side is a self-assessment of cognitive functioning. You'll notice that the first 3 questions ask about the value of having better memory, concentration or focus, and critical thinking skills. So for example, would it be helpful to you if you remember better what you read or heard or learned? What about appointments, events, or things to do? These questions use a positive frame to ask about cognition and emphasize functional recovery over deficit. The subsequent questions ask for any answers, for any items that were answered yes. So yes, it would be helpful to have better memory or attention or better critical thinking skills. Is this a change from an earlier time in your life? If so, when do you think that change occurred? And do you have some ideas about why that change occurred? Why remembering or paying attention or being organized is harder now than perhaps it was at a different time? So these questions help us and the participant understand the time course of any difficulties that are experienced or reported, and helps us to begin to identify the factors that might be affecting a person's cognitive health. Further, the final question asks whether the person wants to learn ways to address any of the issues that they've identified, so we can begin to understand how it is that their cognitive health is prioritized. Next slide, please. Self-report can also be supplemented with collateral information. So this might include team member observations. It could include reports from family and friends. It could include a person's educational history. So their school records, reports from teachers or guidance counselors. Perhaps a person has had an IEP in school. Do they have previous assessment records that they can share? Perhaps a psychoeducational evaluation or a neuropsychological evaluation. Do they have prior diagnoses that you can draw from, such as ADHD or a learning disability? Have they received accommodations in school before? If so, that might inform what has been helpful to them and what might be helpful to pursue or to put into practice in the future. Next slide, please. So any next steps that occur really need to be taken using shared decision-making with the participant. And we can think together about the answers to these questions. Are cognitive health challenges present that impact daily life and/or cause distress? Are there modifiable factors that can be addressed with a reasonable expected impact on daily cognitive functioning? Would further testing help to better understand cognitive strengths and areas of need for the purposes of intervention planning? And is cognitive health a current priority? It's important to consider that assessment is always dynamic, and we need to evaluate participant preferences over time. So it may very well be the case that when you first ask a participant, they may not identify cognitive health challenges or needs, or maybe they don't identify cognitive health as being a priority. But it may be the case that if you ask at a different point in time, when the cognitive demands of their everyday life have now shifted or changed, maybe they are now experiencing difficulties or challenges or evident that they didn't experience before, or maybe now they're prioritizing their cognitive health more than they did at an earlier time. So it's important to continue to have dialogue around cognitive health and to continue to ask people about their perceived cognitive health needs and whether this is something that they feel would be important to address. Next slide, please. Assessing cognitive health may involve formal testing, and some coordinated specialty care teams may have access to a brief cognitive assessment battery. So some examples of a brief cognitive assessment battery include the BACS, such as the Brief Assessment of Cognition and Schizophrenia, or the SCIP, the Screen for Cognitive Impairment in Psychiatry. This is not an exhaustive list. There are many types of screening methods. It may also be helpful to refer out for a more comprehensive cognitive assessment or evaluation. So one case in which this might be useful is if there are complex diagnostic questions. It may also be important or necessary to get testing to receive academic accommodations or work accommodations. And sometimes it can be useful to get a profile of cognitive strengths and relative weaknesses to facilitate more nuanced treatment planning. Next slide, please. All assessment, whether it's self-report or a comprehensive neuropsychological evaluation, should always be followed by feedback and discussion of results. And there are multiple clinical objectives. So, for example, after doing the self-assessment of cognitive functioning, we may say something like, so you identified that attention is not an issue for you. How has having a strong ability to stay focused been helpful to you? So this highlights an area of perceived strength and also links cognitive health to functioning in everyday life. Or we may say, so you identified that memory is an area that you'd like to get better. Now, everyone has strengths and weaknesses. Can you provide an example of how this impacts you in your everyday life? So what this does is normalize the experience of having cognitive challenges and again links cognitive health to functioning in everyday life. We might also say, it's great that you feel that this is an area of strength. Do you ever feel like your ability to focus or stay focused over a longer period of time could be even better than it already is? How do you think that might help you? So a query like this allows for the possibility of discussing cognitive intervention, even if problems aren't readily identified. We also, again, have the opportunity to link cognitive health to everyday life and functioning. Okay. Next slide, please. So let's move on to address how do we integrate appropriate cognitive health services? And I want to emphasize that I don't think that there's a one size fits all approach to improving cognitive skills and everyday functioning. Rather, there are multiple strategies that can be implemented by different members of the team, and so a menu of service options may be provided. And I'm going to review some of these service options that include psychoeducation, strategy coaching, as well as skills training. Next slide, please. So psychoeducation. One aspect of psychoeducation might be to define those smarter skills for individuals and to place each of those skills into a real world context. This helps to make the cognitive skills less abstract, more concrete, and to help a participant better understand the relevance for their everyday life and their recovery goals. By providing psychoeducation, we can also help to connect a person's cognitive health to their mental health and their physical health. All three form the basis for a good quality of life. And when our cognitive health is strong, we might find it easier to attend appointments, remember to take medication. We might find it easier to socialize, which takes care of our emotional health and well-being. We might find it easier to build in exercise and healthy eating. And likewise, when our physical health is strong, we may feel more attentive. We may feel more energized. When our mental health is strong, we may feel more clarity of thought and be able to take on cognitive challenges. In providing psychoeducation, we also have the opportunity to express optimism and hope that cognitive health can be improved. Next slide, please. Providing psychoeducation also gives us the opportunity to help a participant develop a cognitive awareness. That is, what makes it easier or harder to use cognitive skills in daily life? Some people might identify that their mood or other symptoms of psychosis impact how well they feel they're able to call upon their cognitive skills and use them in situations. Motivation or energy level may also impact how equipped one feels at any given time to take on cognitively challenging tasks. You might notice that distractions in the environment can impact how well you're able to pay attention, to focus, or to learn. Some people identify the presence of a support person as being really crucial and beneficial for their cognitive health. And some people may identify that in times of anxiety or stress, they feel that their cognitive health is less strong, that they feel less able to stay focused or remember or to take in information. And at this point, I want to ask you another question, and you can put your answers in the chat. So I've often heard people say, when they go to a doctor's appointment, they get really anxious and worried, and they get stressed out, not only by the fact that they're going to get a physical exam, or maybe you're meeting with their psychiatrist to review your progress and your medications, whatever the case may be, but their anxiety and their worry begins to impact how they think about their thinking skills. And they may get worried that I'm not going to be able to remember the questions that I wanted to ask, or I have certain concerns. And what if I can't recall the information that I need to be able to explain myself properly, or the information is just not going to come out right? Or what if the doctor is giving me information or follow up on what I need to do to manage my health and I can't remember it? And this buildup of anxiety or stress can impact how well they're able to take in and process information in the moment. So again, if we know that feelings of anxiety or stress can impact how well we feel we're able to use our cognitive skills in a situation, we can plan ahead. So if you were in that position, if you realize, and maybe this is true for you too, If you feel anxious or stressed about going into a doctor's appointment, worry that you're not going to be able to remember the things that you wanted to say or the questions you wanted to ask, or remember to follow up on the information that was provided, what are some of the things that you can do to plan ahead for that situation? How can you accommodate your cognitive processing to ensure that you have a successful doctor's visit? So go ahead and put some suggestions in the chat, and I'll take notes on my phone. I'll read them out as they come up. Take notes on my phone. Excellent. So note taking is an excellent way of keeping track. Make a list of questions prior to the appointment. Yes. Invite family or friends to join you. Sure. Invite a trusted support person to accompany you. That might help alleviate some anxiety or stress, and it would also provide another set of eyes and ears for the information. Yeah, so writing things down ahead of time, making a list of questions and bringing that with you. If you know that you benefit from the act of writing, maybe a written list is helpful. Putting it on your phone, if you always have your phone with you, that would be beneficial. I've also heard maybe even emailing the doctor your list of questions ahead of time. So that kind of makes sure that while you're in a place of calm and you have the opportunity to think clearly, you've got that information sent out to the doctor ahead of time. I've also heard people suggest that, the doctor give you a call afterwards and summarize the visit on a voicemail message that you can then refer to. Right. So writing things down, having a support person with you, these are ways of problem solving a real life situation where we might feel it difficult to use our cognitive skills. So when we provide psychoeducation, we can use these sorts of examples, and we can express that it's totally understandable to experience difficulty with thinking skills under certain circumstances. And we can then problem solve and plan ahead to make allowances for these factors in daily life. Next slide, please. Another aspect of psychoeducation might be working with family members. And here you see depicted a handbook for families and friends. This handbook, called Dealing with Cognitive Dysfunction, describes how mental health conditions can affect cognitive processes and functioning, and it goes into more detail about how memory, attention, and critical thinking skills can be supported by structuring the environment, using aids, and providing encouragement and emotional support. This is a no-cost, easy-to-access resource. It can be used independently or in combination with any other method. It's also available in English as well as in Spanish. Next slide, please. Pharmacologic optimization. So there's no currently approved medication to treat the cognitive symptoms, but psychiatric care providers do play an important role. So those in a prescribing role might consider the primary versus secondary causes of cognitive difficulties, including the possibility of medication impact. So one might evaluate the dose or medication type, or both. Might consider changing the timing of when medication is administered to alleviate the impact of sedating effects, which can impact how well people say that they're able to stay focused or pay attention or take in information. You can make efforts toward reducing polypharmacy and, importantly, minimizing anticholinergic burden, which can impact cognitive skills. Of course, when making any medication change, we always need to use shared decision making and consider the potential impact on symptoms versus side effects. Next slide, please. Many coordinated specialty care teams that I've worked with have already integrated strategy coaching within their work. Here, I'm going to call out what some of those strategies are so that they might be used more consistently and intentionally. In fact, many people use strategies in daily life without even realizing it. But not all people do, and not all people choose strategies effectively or consistently. So strategy coaching as an approach involves generating and selecting useful strategic approaches based on a person's known areas of strength, their knowledge of what works well for them and what doesn't, as well as the type of task, and then coming up with appropriate strategies given the task at hand. Next slide, please. So there are a variety of strategies that we can use for memory, attention, and organization, problem solving, etc. So when we think about memory strategies, for example, there are a wide variety of information processing aids that help to facilitate more efficient and accurate information processing. You see on the left-hand side a list. This is not an exhaustive list. These are just some examples of ways that we can facilitate information processing to help information stick so that it's more likely to be recalled when we need it. So some strategies might be verbalization or self-talk, so saying aloud or to yourself the cues, items on a list, or steps of a task. Rehearsal is repeating information or the steps of a task over and over to gain mastery. Chunking is dividing large amounts of information into smaller groups to make the information easier to process and remember, kind of like what we do with the phone number. Creating associations is another technique where we link words or concepts together in a way that makes sense and makes that information memorable. And even to pull another one in, using mnemonics. So the acronym SMARTER, right? Each letter of the word SMARTER stands for a different cognitive skill. So we've condensed a lot of information into a singular word that is easily remembered. In addition to information processing aids, there are also workarounds that we can teach and practice. These workarounds offload some of the cognitive demand. So we write things down. As we said, we're taking notes. We create habits or routines to make behaviors more automatic. We use alarms, that may be like an auditory cue that something needs to get done. Or we use sticky notes, which is a visual cue or a reminder that something needs to get done. You need to take something with you, or maybe it's a visual cue in your planner that there's something important to attend to. Next slide, please. Attention strategies are similar. There are information processing aids as well as workarounds. So strategies might be, again, verbalization or self-talk, saying aloud to yourself the cues, items on a list, or steps of a task. This helps you to stay focused in the moment and process that information that you need to be attending to. There's also information reduction, where you cover up information to reduce distraction. I often think about when you go to the doctor's office for the first time, you've got all those forms to fill out. Those insurance forms are so dense. There's so much information on a page. It can feel really overwhelming. And so one strategy is to take a piece of paper or something, magazine, and cover up the bottom half, and then just to look at each line individually and fill in the information and slowly reveal line by line so that you're less overwhelmed by the amount of visual information that's presented. There's also multimodal presentation, so processing information in multiple modalities, very much like what we're doing right now. You're listening to me talk. You're also looking at the words on the screen, which reinforce what you hear. And maybe you're even writing notes at the same time as well. There are also workarounds to facilitate better attention. We can reduce distractions. We can use a timer for a set period of time. So if I know that I can concentrate well for 25 minutes, I might set a timer for that amount of time. And when the timer goes off, I take a scheduled break. Some people also use sensory tools like fidget spinners and stress balls to help them stay focused and in the moment. Next slide, please. There are also tools for planning and organization. So if we think about chunking down recovery goals into its component goals, into smaller goals or tasks. So we might use weekly goal setting and chunk goals or tasks by time. So putting a set amount of time to make progress towards a particular goal, or enumerate a set of tasks that we want to do according to a schedule. We might then use prioritization and time management techniques to help make sure that we get those things done. So we use calendars and planners and to-do lists. We can use time estimation, which is like a behavioral experiment where one behavioral experiment where we estimate the amount of time it's going to take to do something, and then we actually see how much time it takes. And then we can then plan ahead for the amount of time that we need to allot in order to get something done. Next slide, please. Skills training interventions can also be offered depending on the resources and the implementation culture. So expectations for coordinated specialty care participation. So whether your program uses groups or individual sessions, and what the expectations are for in-clinic visits. So CogSmart is a really great resource. This is cognitive symptom management and rehabilitation therapy. This is an evidence-based manualized intervention that includes tools and strategies to accomplish cognitive tasks in everyday situations. It targets attention, learning and memory, and executive functioning skills. breaking down skills into weekly sessions that can be held individually or in groups. No computers are required aside from the initial download, and it's translated into multiple languages. Next slide, please. Cognitive remediation is another type of skills training intervention. This one uses computer-based exercises to target and strengthen specific skills, while a trained therapist provides coaching and support. Cognitive targets may range from basic sensory processes to fundamental processes like attention or memory, and complex skills like problem solving. Importantly, we use a technique, sometimes called bridging, which is a verbal discussion where we put these cognitive skills and strategies into a relatable context. We link cognitive skill use to real-world function. It's important to identify and carefully evaluate the resources you have available, as well as fit for your clients and program. So this is typically structured as a small group therapy. You need a sufficient intensity and duration of cognitive practice to make appreciable and sustained gains. So cognitive remediation sessions are typically run at least twice weekly for 1-hour sessions over the course of 12 to 15 weeks. There's a bit of variability there. Some programs are longer, some are shorter, and there are a variety of evidence-based programs out there for consideration. Next slide, please. So I want to go back to this idea that all team members play a role. All team members interact with an individual in unique ways and contexts. So for example, a peer specialist might normalize the experience of cognitive challenges and check in on how the client feels about the cognitive health supports that are being provided by the other members of the team. The primary clinician would assess for cognitive health needs, provide education, work collaboratively with the participant to figure out which supports or interventions might be most useful. The supported employment education specialist might ask about cognitive challenges at school or at work, and then reinforce the use of strategies in that specific context. And team members would then collaborate to coordinate cognitive health services and supports. Next slide, please. Okay, so putting it all together. Cognitive health services in the context of coordinated specialty care require a model that integrates cognitive health care with other personalized recovery-oriented services. We value multiple perspectives and collaboration across team members. We always need to be using shared decision-making with participants. We can use a workflow that incorporates the 3 pillars of cognitive health service: ask, assess, and address, and that fits the implementation context. Again, considering what assessment and intervention resources you have available to you, and the expectations for group versus individual work, and the expectations for clinic attendance. Finally, last but not least, and most importantly, we need to ensure that we are discussing cognitive health needs and making recommendations and providing services that meet your clients' needs and their stated preferences. Okay. And that concludes the didactic portion of today's webinar.
Thank you so much, Allie. That was so informative and so helpful. There were so many resources there. I think that was excellent. So right now during our session, we're going to go through some of the questions that we've received and pose those to you, Allie. So one of the questions we wanted to just get your take on is, what if a young person who's receiving services does not necessarily indicate or state themselves that they have any difficulty with cognition, but perhaps they show signs, or maybe you hear reports from a family member that they show signs of cognitive impairment, like forgetting appointments or appearing highly distractible? How would you go through addressing that?
That's a really good question. Thank you for that. So it may be the case, right, that the person does not come out and say that or recognize that they have specific cognitive difficulties. And most often you're not going to hear somebody come out and say, I have difficulty with processing speed, or I have difficulty with my working memory, right? And so it's really important to use that cognitive lens and really listen to what people are saying and how they frame their experiences in terms, and you can reframe what they say using their words in terms of cognitive terms. So you might hear somebody saying that information just doesn't stick, or you might hear that they have experienced sensory overload, or information is just like too much or coming at them too quickly and they can't keep up, or my mind freezes up and I can't think straight. And when you hear those sorts of experiences being relayed, you can delve a little deeper into what that feels like. And it may be the case that the person is experiencing a cognitive challenge, they just don't frame it in using the same language or in the same terms that you might. And so it can be helpful to explore that experience with the person and see if, by providing a definition or more information about the variety of cognitive skills, it is in fact that it's difficulty with speed of information processing, or they feel that it's really hard to stay focused or to select out from all the things that they're exposed to, what it is that they're meant to focus on. I think another thing that's important is that when we ask about cognition, that again, as I presented in this webinar, that it's important how we frame questions if we're asking about cognitive difficulty, to frame things again in terms of real life experiences, and to not necessarily ask about, do you have problems with X, Y, and Z, but rather, as I presented, would it be helpful if this were better, even maybe than it already is? We can emphasize what the value might be of being able to think more clearly, or whatever it is that the person is describing. We can also use ourselves as a model and normalize the experience of cognitive challenge. Sometimes people do feel shame, and there's even stigma attached to experiencing cognitive difficulty. I think it's not well understood in many cases. And so again, providing some psychoeducation while having these conversations with people can be enormously helpful. And then finally, I would also see if you can talk with the person about what's working well for them and highlight areas of strength. And then you can ask further, how that approach is working well for them. And maybe there are aspects of their system or strategies that they use that could be even better than it already is. So in that way, you can kind of continue the discussion around cognitive health needs, even when the person doesn't come to you or readily recognize the fact that cognitive challenges may be occurring.
Right. Mhm. Great. Thank you for that. Another question we have is, are there cognitive practices or methods that are better for certain age ranges than others?
Um, I think so. I know that methods of cognitive mediation are effective, for example, in a range of ages. It may be the case that for older folks, a longer duration of treatment would be necessary, but really these sorts of interventions are effective across age ranges. I think the language you use might vary based on the age, as well as how you frame your discussion around cognitive challenges. So of course it needs to be developmentally appropriate and put into a context that is that's going to be accessible to the person. But in general, I would say these sorts of approaches are really effective and can be implemented across age ranges, really across the lifespan.
Mhm. Great. Another question we have is about family members and how can family members be brought into the framework of cognitive health services?
Great. So of course, in the coordinated specialty care model, we have to ensure that from the participant's perspective that they've identified a support person or family member that they want to involve in their care, that is considered a part of their team. In some cases, it can be helpful to, again, provide psychoeducation to family members. I did share one of those resources. Just drawing from my experience and what I've heard, um, there are two kind of sorts of experiences I've heard in regard to family members. One is a case where cognitive health isn't necessarily very well understood among family members. And so you might hear that like, well, they're lazy, or like, they don't understand why they're just not doing what it is that they've been asked to do, or they're not following up on conversation that they had. They're just not trying hard enough. Or maybe there are other cases where cognitive health is understood and appreciated, and the challenges that the person experiences are appreciated. And and clinicians can do this too, but family members might as well, that we care so much and we want this person to be successful that sometimes we wind up doing things for the individual. And that in either case, psychoeducation can be really important and helpful. We might teach the family members how to scaffold cognitive activities, so that the person can experience success and talk about what skills and strategies were helpful for them to have a positive outcome in doing a particular cognitive task, and then slowly withdraw some of those, the intensity of those supports, to help foster independence. We also need to ensure that the person, the participant, feels empowered to make choices about how their cognitive health is addressed and how family members are, in fact, involved in addressing their cognitive health needs. The type of help that they want or need with cognitive tasks may vary from time to time or task to task, and it may evolve over time. So there are different ways in which to involve family members. And it's important to put the ball in the participant's court and having them choose how they want that family member involved. So one example might be that a family member might do like a partner do together. So they're doing a cognitively demanding task together. A different way would be to do parallel work. This is sometimes called body double, right? Where the one person's doing, a cognitively demanding task like doing your taxes or studying for an exam, and then somebody else is doing cognitively demanding work as well. And they're not directly helping the person, but they're working side by side. It's a warm body in the room, and they're both, it's like setting the environment. Like, if you have to study, you might go to the library because it's a quiet environment where there's this atmosphere of concentration. And so it sets the stage for productive work. And then there might be times where the person wants to have a check-in. They don't want help with a task in particular, but it might be helpful to schedule a time, let's say at the end of the week, where they know that there's an opportunity to talk through what they've accomplished with that family member, and then get some assistance or support in problem solving, what didn't get done, or how they would like support moving forward. So I think there's a lot of roles and important roles that family can play. All the while ensuring that help is provided in a way that still centers the participant and gives them, empowers them and gives them choice about how their cognitive health is addressed.
Very helpful. We have another question that is from a participant. Our hospital firewalls prevent access to most online cognitive training resources. So they're asking if you have any recommendations for low-tech options that target specific areas of cognition.
Sure. Yes. So programs like cognitive remediation often rely on web-based platforms for skills training. Yes, that can be an issue. Access can be an issue with those forms of skills training interventions. There are other less low-tech options. So CogSmart is one of those. CogSmart is one of those cognitive skills training interventions that is low tech. You do need a computer to get all the materials, and I think that I hear they now have an app as well. So you might be able to use your phone. I'm not 100% sure on that, but cogsmart.com. I totally recommend you check that out. But that uses more written. You can use more written materials. You can print the manual, and then all the worksheets and everything can be used like pencil and paper. The integrated strategy coaching is another way of just folding in or integrating discussion around cognitive health supports and strategies into routine practice. So it's not a formal. So you could do it formally, like CogSmart, but you can also do it informally. So as cognitive challenges arise, there are a variety of ways in which you can teach those information processing skills and workaround strategies to help people figure out what works best for them and practice them with you in session, and then do some practice outside. And that's again where multiple team members helping the person to practice those skills and strategies and reinforce use in different contexts can be extremely helpful. And they can be practiced at home as well. So family members, again, can play a role there. and reinforcing the use of skills and strategies for memory or attention or problem solving, planning, organization, time management, etc. One last resource, if you have the ability, if you to check out a website called Teach Recovery, teachrecovery.com, it's one word. There's a great it's a great website that I have the privilege of contributing to, and there are a variety of resources there as well. So you'll find manuals, you'll find implementation materials that can also support how we can support cognitive strategy development and use in routine practice.
Great. Thank you. I think we have time for one more question in the next couple of minutes. You mentioned how important it is for all team members of a COC team to be involved in the process of helping folks with cognitive challenges. And one question is, how can I get my team trained in cognitive remediation therapy?
Great question. So if you're interested specifically in cognitive remediation therapy, I have particular training in one program that's called the Neuropsychological and Educational Approach to Cognitive Remediation. You may want to check that out. You can access a variety of materials, so this is also helpful for those wanting more resources. The Center for Practice Innovations has a whole learning management system. You may be able, if you might already have access to CPI, if not, it's possible that you can gain access. So within that learning management system, there's a whole section called Cognitive Health Solutions that has a variety of trainings there. So there's information about cognition, there's information about cognitive remediation specifically, and there are 2 new modules called Cognitive Remediation to Promote Recovery, part 1 and 2, that is online training for setting up and running a cognitive remediation program. Feel free to also reach out to me directly if additional training and support for that method would be useful. I will also say that, again, and as I said before, there are many programs of cognitive remediation out there, and I know that there's also a website in development that hasn't launched just yet, but it will be an additional resource that people can go to learn about the variety of programs available to implement cognitive remediation, and there would be links on how to receive training in any one particular method.
Fantastic. Thank you so much, Allie. This was so helpful. I think we only have a few minutes left, so we just have a couple of different follow-up closing slides here. Your feedback for everybody who's attending is so welcome, and we really appreciate your insights and feedback. So here on the screen is a QR code and a link to a feedback form. So if you go to this, you can give us feedback on today's session, and we'd love to hear what you all thought. So I'll just give maybe a minute or so for people to either get this in the chat, or the link itself is in the chat as well as this QR code. So if you go to that, it would be great to get your feedback. And like I mentioned, as people are going and filling this out, we will be sending out slides to folks after the webinar is over. So if there are resources and other materials, we'll be able to share those as well. So I think there are so many great resources that you described, Allie. So I think it'll be very helpful for people to know more about. As people are finishing up or going to the feedback form, maybe we can go on to the next slide, which will just be a quick recap of some of our upcoming ESMI TTA Center webinars. So we have one webinar each month as part of this series. The next one that we have is on May 13th, and that is going to be the role of peers in early serious mental illness programs. And we have 2 great presenters who are from On Track New York who will be presenting during that webinar, and the registration information for that webinar about peers is actually in the chat now. So if you go to that link that's in the chat, you can sign up and register for the role of peers in ESMI programs webinar. We also have a webinar coming up on June 17th on supporting young adults experiencing early serious mental illness and the shift from child to adult mental health services. So that's going to be on June 17th at 12 p.m. Eastern. And then we have one July 15th, which is going to be sort of summarizing some of the findings from the first cohort of SAMHSA's clinical high risk for psychosis grantee program. So we'll be able to share some data, some results about what the findings from that particular grantee cohort are. So that is what's upcoming, and we'll be sharing the registration information with all of you as we get closer to those webinars. But feel free to sign up for the peers webinar. And I think we just want to say thank you as we round out the hour. Thank you all so much. We'll send out Allie's information as well if you want to ask her for any follow-up questions, and the ESMIT Center website and email address is listed here. Thank you all so much. Have a great day.
Thank you.
Bye-bye.